This program is solely made to help the practicing vitreoretinal surgeons during COVID times and is a work of non-fiction. The authors do not have any financial disclosure in the subject matter of this film. The COVID-19 pandemic has caused a major setback across the world. The medical community is affected in more ways than one. The safety of the healthcare professional is of utmost importance as we are involved in patient care, some of whom may be positive for the infection. It has been well documented that COVID-19 can be transmitted by aerosols. So, our question was, are aerosols generated during retinal surgeries? Even if they are generated, do they pose a risk? To unravel these mysteries, we conducted a series of experiments in collaboration with the Indian Institute of Science, Bangalore. PhD scholars led by Dr. Basu from the fluid velocimetry team helped us in this setup. Shadowgraphy using a high-speed, ultra-high resolution camera which can capture 5000 frames per second, that is 100 times more than what a smartphone camera can do, was utilized to detect the smallest of aerosols possible. We conducted our experiments on enucleated goat eye with vitreous being stained with brilliant blue and used an Alcon constellation system for vitrectomy. Aerosol generation was ascertained for intravitreal injections, different gauges of trocars and cannulas, valve versus non-valve cannula for lensectomy and vitrectomy, passive and active fluid air exchange, removal of cannulas and suturing. During intravitreal injection, insertion of cannula, lensectomy and vitrectomy with both 23 and 25 gauge instruments with either valved or non-valved cannulas, we did not find aerosol generation which was confirmed on shadowgraphy. Even with a 20 gauge MVR blade, there was fluid flow but no aerosol. During active fluid air exchange, we did not find any aerosol generation. However, while performing passive fluid air exchange using a Charles flute needle, we found bubbling and aerosol generation at the exit port of the annule. As expected, under fluid air exchange with reused valve and fresh non-valve cannulas, aerosol generation showed a trajectory of 0.4 to 0.67 meters with droplet sized 200 microns. While removing cannulas or suturing under active air infusion, bubbling and aerosols were noted. Based on our experiments, we recommend use of valve cannulas whenever possible. To avoid passive fluid air exchange, even if done, direct the exit port away from the surgeon and the assistant. To maintain air pressure at less than or equal to 30 mm of mercury, to stop active air infusion or clamp the infusion during removal of cannula and suturing. Last but the most important, usage of adequate personal protection is mandatory. Based on these experiments, vitrectomy appears to be a safe procedure during COVID times.